welcome in nursing webinar session. Myself Shanti, the Vice President Nursing. Today we are going to discuss about the robotic prostectomy and pre and post-operative nursing care. We have with us Dr. Raghuveer Garu, who is our expert panelist. He's our consultant urologist, laparoscopic, robotic and renal transplant surgeon who is highly skilled in his interventions from Secunderabad, Yashoda unit. Let me also welcome Ms. Chinnama, who is our dynamic nurse manager who heads the medical and surgical nephro and uro ward. Okay. So I welcome you, Chinnama, and let us also see the slides what we have in today's session. So let us also understand the prevalence. As you all know, you can share the slides of prevalence. As you all know, we always talk about the epidemiology or prevalence of the disease condition. So if you look at the prevalence of prostate health in the era of advanced urology, okay, and because Dr. Raghuveer will be joining us within very short span of time, he's a little engaged with the surgery. So the male reproductive health, yes, sir. So let us only hear from sir. I am sorry that you're not getting much of time to even breathe. So can you unmute yourself, sir?
Right.
Yeah, so again, I would like to reintroduce sir. Sir is our very expert, eminent, as a very senior, highly skilled transplant urologic and renal transplant surgeon. And today, sir is here with us as an expert panelist, and we would like to understand the prevalence of prostate health in the era of advanced urology, sir. The first.
The prostate problem itself is usually the elderly age problem. So whether it is a benign problem or it's a malignant problem, it's usually is affected after 55 only, by and large. There are exceptions to everything, but usually it happens after 55, 60 years. So the prevalence of CA prostate increases with age. So about if you see 50 to 59, the percentage is less than maybe 3% or so. But if you take above 60, usually the incidence will increase. And moreover, the Asian population are a little bit lucky when compared to African Americans and all. So the prevalence among the American and this group is much, much higher than the Indian or maybe Asiatic population.
Yes. So let us also see what we have in rest of the webinar sessions. We'll be keeping the session very time bound, and Chinnama, you can just talk about the fourth slide onwards. Yeah, go to the third slide. Yeah, we would also like to share the patient success story where expert eminent urologist we have and many more at our setup. As you can see, the international patients also have they were our patients and they have gone very happily because our expert eminent urologist they have really given them the very beautiful outcome in terms of prostectomy surgery and else. So go for the fourth slide and you can start.
Thank you, ma'am. I'm Chinnama, myself Chinnama, nurse manager. Today, my topic is, we have a webinar on robotic prostectomy. Before I go to that, I would like to talk about the anatomy of the prostate gland. Prostate gland is the reproductive in the male person. The primary function of prostate gland is to produce semen.
Yes.
So what do you mean by robotic prostectomy? Robotic prostectomy or minimal invasive procedure for the surgery for the CA prostate, especially when there is when it is indicated and when it is directly diagnosed as prostate cancer.
So, sir, here also we would like to understand, is the robotic prostectomy surgery is better than the open simple prostectomy or the open approach? Your opinion?
Yeah, definitely it is better than open and laparoscopic approach. So, laparoscopy again is a minimally invasive surgery. Open, obviously, the name itself suggests we have to open at least maybe give 8 to 10 centimeters of incision, go through all the layers and do the surgery. But yes, the issue with the laparoscopy is the suturing. You have to connect the bladder with the urethra because the prostate lies in between the bladder and urethra. So we are removing that part and we have to rejoin the bladder and the urethra, so that anastomosis will be very difficult in laparoscopy because of the region. It's a deep in the true pelvis where we don't get much space to move our hands and all. So definitely robotic scores over open and laparoscopic surgery. There is no doubt when it comes to prostate, definitely robotic is better.
Yeah, you can go for, just keep sliding, yes.
So now I would like to talk about when the robotic prostectomy or prostate surgery is indicated. So when there is a clinically localized prostate cancer or persistent or chronic UTI, that is urinary tract infection, BPH, benign prostate hyperglycemia, and urinary incontinence, significant or recurrent hematuria. So there will be some, as we see in the images, there is a bladder calculi, secondary to bladder outlet obstruction.
So apart from all these indications, what we are just looking at the images, only the surgery is indicated only for the the prostate cancer, or in in terms of severe incontinence or urine problem also, sir?
No. See, the prostate, there usually we do two types of surgeries in prostate, but grossly, one is for bladder outlet obstruction. So usually the benign BPH, what we call our benign prostatic hyperplasia, that is the most common reason for prostatic surgeries. Usually we do it in the form of TURP, transurethral resection of prostate. Whatever energy, that is a different issue, whether you use monopolar, bipolar, laser, or whatever it is. But most of the time the procedure is TURP. Even if there is a stone also, we will try and do it endoscopically only, CLT or PCCL, whatever is the name. When it comes to carcinoma prostate, because the main difference is in a benign prostate, we will remove only part of it. Whatever is causing obstruction, that much only we will remove. Rest of the prostate is still with the patient only. But when it comes to the cancer, the main aim is to remove entire prostate. We don't want to leave anything behind. So that is where the major difference comes. So for carcinoma prostate, we have to do something called radical prostatectomy. And the main means of doing the surgery is robotic, lap or open. But when it comes to benign part, we will do TURP. So that is transurethral resection.
So very great to know about these knowledge disseminations which you are giving to us, sir. And yes, Chinnama.
So now I would like to talk about the types of prostectomy. So robotic laparoscopic approach and open approach. So as we see in the images, there's a robotic instruments which they use through laparoscopic instruments, and there's one more image shows open approach.
So which approach you get to see, in more among these two?
So see, there are two main things now. Now the surgery of the prostate is open and minimally invasive. So minimally invasive consists of both laparoscopy and robotic. That is on one side, and open surgery is on one side. So open surgery, they have the picture is showing retropubic approach, perineal approach. So whatever you are comfortable, you can do. But actually, these are little surgeries, little are not popular nowadays. Almost now every center who want to do the prostate surgery is shifting towards laparoscopy and robotic surgeries. So these are the two things. And when it comes to minimally invasive also, there are two approaches. One is intraperitoneal, which is the most commonly done approach. So you have to go through the peritoneum, insufflate the peritoneum and do your surgery. And there is something called retroperitoneum or extraperitoneal surgery. So you don't enter the peritoneum only, you create space in between the abdominal wall and the peritoneum. From there you go and you remove the prostate. So these are the two main approaches when it comes to minimally invasive, but by and large, most of the people around the world uses intraperitoneal approach. So that is more common and more like everybody understand the anatomy better.
Yes, yes.
So as Sir said, there is a retropubic and perineal approach. So Sir has already explained in details. Now coming to the signs and symptoms of prostectomy. So the first one is urinary incontinence, and all signs and symptoms will not be same for each patient. Depends upon each person's signs and symptoms. So urinary incontinence, where patient is not aware of there is a dripping of urine, or patient doesn't have control. Then there is a trouble urinating, decreased stream of urine, blood in the urine and semen, weight loss, and erectile dysfunction.
So, sir, do we get to see all these signs and symptoms whenever the client comes to your OPD or as an IP patient?
as such, the symptoms exclusively related to the carcinoma prostate is very rare.
Yes.
So most of the times patients will come to any of with these symptoms like incontinence or thin of urine, they are straining to pass urine, hematuria, all those things. So again, the most common reason will be BPH, that is benign prostatic hyperplasia. So there is no such specific symptom that only cancer prostate will have and BPH doesn't have. So only during the evaluation, most of the times we will come to know that is the it might be a CF prostate, and then we evaluating those lines. Rarely patient will already come up with bone pains, especially spine and hip pain and all. And any elderly patient who comes with that, and if their PSA levels are raised, we have to suspect CF prostate. So that is little advanced stage of prostate that is presenting with a symptom. As such, there is no symptom specific to CF prostate.
Yes. Or
These symptoms are all, any prostate will have all these symptoms, a combination of any of these things.
Okay. Yes, sir. Yes.
Yeah. Right.
So as I would like to tell about the age group of the male persons who are undergo the prostate. So as we have searched it, most of the patients who are above the age of 50. And once the surgery is over, there is lifespan is 10 years, ma'am.
So I think many of us, we consider this as a myth, or maybe it is a fact, sir. If at all you see, look at this age group.
Yes.
Yeah, so usually I think the little got it slightly wrong here. So the obviously the risk increases with the age of the prevalence of CF prostate, but usually surgery will be advised to those patients who has a minimum lifespan of 10 years. Previously, they used to do like a 60 to 65 or 70, and then if they are more than 70, they used to give radiotherapy and all. Nowadays, the most commonly practiced thing is anybody, he is 70, 80, whatever it is, he is hale and healthy, and if suppose you think that he can live at least another 10 years, he can be subjected to radical prostatectomy.
So this is how I think we always wished to clear from your point of view. So great.
Yeah, right. Yeah.
So now I would like to talk about the risk factors of surgery. So like bleeding, urinary tract infection, urinary incontinence, erectile dysfunction, narrowing of the urethra or bladder neck, and formation of cysts containing lymph, as we have seen in the picture.
So if these are the possible risk factors or causes, do we get to see with this risk factors for post-surgical patients, or if we get to see how many like
the
prevalence?
bleeding in prostate case is usually not that much. It's not a main complication of the prostate surgery. Because there are no major blood vessels, like you are really dealing with major blood. Yes, intraoperatively there is a problem, but once you get hemostasis intraoperatively, post-operatively bleeding is not very common. This UTI can happen because there will be catheter for 10 days or 14 days. It depends on the surgeon who is operating. So usually by and large 10 to 14 days is the catheter. And the formation of cysts containing lymph is like a lymphocyte and all can form, because there will be many a times lymph node dissection also along with. It's not just removing the prostate, you have to remove whatever the lymph nodes are there in the pelvis. So that about the external iliac, common iliac, all those things. So that will cause little bit of this thing. But these are all little these two main things that people are worried about. Prostate is the erectile dysfunction, especially the Western population. Erectile dysfunction in India is not that much. We don't give so much importance because the age group that is undergoing surgery is usually above 65. So in that age, usually Indians are not very much bothered with erection and all. But yes, Western population, they are very particular about erectile dysfunction. Main problem, which at least Asians or Indians feel, is about urinary incontinence. So usually that also within maybe anywhere ranging from 1 month to 3 months, most of the people it will get settled down. Rarely, maybe 5 to 10% of cases, it persists for more than a year or so, who will require further management and all. And yes, narrowing of urethra can happen. That is, many a times it's a technical glitch.
Yes.
So now I would like to talk about the assessment which we doctors do and the nurses do. So first one is complete urinary examination, where we find out pus cells, RBC, bacteria, because of there is a urinary tract infection. The second one is uroflowmetry. Uroflowmetry is a graph where the doctors understand how patient passes, whether patient struggle to pass or patient has at the beginning patient will not pass. Sometimes once he push the pressure and pass. And second one is ultrasound prostate gland, and there is on blood sample, that is a PSA, prostate specific antigen, which is the indicator for to find out abnormalities. Like a normal value is between 0 to 4 Ng per deciliter. And one more is transrectal ultrasound. So PSA is substance made by the prostate gland.
So I think we get to see all these, investigations which is being advised by you also. I think we will go with the same, and these are the prostate markers, I guess.
Right.
Yeah.
Yeah. So now I would like to talk about the nursing management of the patient pre-operative. So first of all, we have to explain the patient about the procedure, about the NBM, nil by mouth, at least 12 hours of fasting, part preparation from chest to below the thigh level, bowel preparations, obtain consent, and PAC, administer pre-medication as advised by the consultant, shift to OT on call with all the reports, and follow all patient safety goals from the identification till the prevention of falls. Next, again, yes, ma'am. It is a pre and pre.
Post-operative also you can discuss, and then we will ask. So,
yeah.
Post-operative, yeah.
Now coming to the post-operative management, as we receive the patient, we have to monitor the vitals. It is very, very important to maintain patient stable or not. Then comes the care of catheters and drain. We have a catheters, we have patients comes with catheter and drains. Sometimes there will be drains, sometimes but drains will be there. And alternative dressing. Dressing also we have to check for the site of the surgery site. There is oozing, bleeding, soakage. And the day one, actually patient will be on IV fluid management. Pain management is a must. And day two, the patient will be liquids and as well as IV fluids. And day two, the diet will be started and patient will be mobilized. Drains, if the drain is minimal, according to doctor advice, even drain removal also can be done.
So Chinnama, do you get to see all this, dressing? Do you all monitor? Do you all teach your nurses also to monitor the site and inform to the consultant or to the team when they come for rounds?
Yes, ma'am. Yes, ma'am. As actually we teach the sisters to check for the patients from head to toe, because drains, we will check the patient, we will check the sisters to check for the drain side if there is any hematoma, redness, any oozing, or order of the dressing also you have to check for it, ma'am. So these are the early warning signs which we inform to doctor. So the doctor will come and take care of the wound, ma'am.
So, sir, do you also agree with all this pre and post-operative care? Is it so good, or would you like to add something from your end?
Yeah, obviously any surgery vitals, and there are obviously, when it comes to prostate, there are two things. One is the drain, one is the catheter. Catheter is the most important thing. Obviously, drain, once patient starts on orals and the drain comes down, usually we pull it out. But the very important thing is obviously catheter management, because we expect the catheter to be there at least for 10 to 14 days.
So catheter care is important. Yes.
Especially to prostate. Yeah, most important is catheter. Or is it tense? That is actually patient. Everybody should keep their eye on.
Yes. Yeah.
Now I would like to talk advantages, sir. So there is a reduced risk of post-surgery incontinence and impotency, and minimal bleeding, early healing, and reduced hospital stay. And there are contraindications which I would like to talk, sir. There is absolute when there is uncorrectable bleeding, where the patient has a bleeding tendency, so the patient is not supposed to go for surgery. And patient with severe cardiopulmonary compromised patients also better, we will not advise, no, sir. And the second one is relative. History of complex lower abdominal or pelvic surgery, and history of transurethral resection of prostate, unless it is contraindicated to prostate cancer, sir.
So if at all the patient has all such kind of contraindication, do also we wait till they settle down and then we proceed with the surgery later part, or what is the criteria for surgery, sir?
With the cardiopulmonary this thing, we need to take the help of the cardio people or pulmonology people. We should have to need to optimize them as much as possible, and we can, once we get the fitness, we can take up for the surgery. And when it comes to already patient has lower abdominal surgeries or pelvic surgeries or post URPs and all, it's very difficult to for any minimally invasive surgery. Then the option will be more to go into the open one.
So as I have discussed before regarding the early warning signs which we need to inform to, which we have to notify to doctor, like fresh bleeding at surgical site, fever more than 2 spikes, signs of infection such as I told, if the sisters have noticed redness at the surgery site or any oozing or any kind of fresh blood or any bad odor in the surgical site. So now possible complication. There may be possible complication regarding this surgery like vascular or bowel injury, rectal injury or hematoma, incontinence, and sometimes the patients may go into depression.
So do you also see somebody who approaches you for the reason of depression? As you have already mentioned, the ED is not very much flaring in Indian setup, but I think they are also worried about their these are possible complications, and also do you get to see them, sir, in your opinion?
Yeah, the first two things are immediate complications. So they will be there and then intraoperative or immediate post-operative, they will be dealt. So there won't be any issues there. Only the, incontinence is an issue. Maybe the Indian population, if the incontinence is persisting and they have to use diapers, or maybe there is some amount of social stigma that they can't go into functions and all, they can't go into people. Yes, they might go into depression. Yes, that is one possibility. Yes.
So we have come to the preventive aspects as it is a golden thumb rule that the patient should always approach the healthcare industry for the early detection, and prostate screening is must, because many of the population, they are aware but they don't come for the prostate screening. Regular exercises and eating healthy diet, maintaining a healthy weight, avoid smoking and drinking, increasing the level of vitamin D, and staying sexually active is one of these are the preventive aspects, sir. I think you will also add on your few points towards the same.
Yeah, yes, actually, when it comes to CA prostate, there is nothing like we can do something and we can prevent it, like because most of the times it's we even today nobody knows exact etiological factor. Like for example, smoking causes lung cancer. Something that is not there for prostate cancer. There is nothing like that. But the most important population is the people who has family history. If the cancer runs in the family, then those people are really, they should take care of themselves. They should undergo screening at PSA screening at early ages, and they require, and the rest of the things everybody should follow. The most important regular exercise and healthy diet, that is mandatory for almost now for everything. So yeah.
So that's how we have come to the end of the discussion. The conclusion: with the increasingly aging population, as sir has rightly mentioned, in almost all societies, this will become even more prevalent and a major challenge in the future. Apart from medications, as sir also said, whenever there is a cancer flare and family history, we cannot avoid, but then early detection and screening is must. So we at Yashoda, unit, we do all this, investigations on high advanced urology procedures and surgeries. Do seek our help, and thank you, sir, for your very valuable time. Apart from your busy schedule, you have contributed so much for nursing webinar. Thank you so much, and thank you, Chinnama, and we end the session today. Thank you.
Thank you, ma'am. Thank you so much.
Yeah.
Thank you, sir.